If you work in an acute care setting, or really anywhere a patient might decide to leave unexpectedly, you know the form we're talking about.
Oh, yeah.
The discharge against medical advice, the AMA.
It's become this healthcare talisman, hasn't it?
It really has.
The thinking, especially, among junior providers, is that getting that signature is the one move that makes you invincible.
Right. The patient was warned, they signed the paper, liability just vanishes.
Oof, gone.
And that assumption that the AMA signature is some sort of legal panacea is exactly the high stakes myth we need to explode today.
It is, because our sources make it abundantly clear that a simple signature on a generic form is often, it's just a receipt.
It's not a legal defense on its own.
Not at all. So our mission in this deep dive is to dissect exactly when and how the AMA form protects providers, and, more importantly, to define the critical specific documentation you need to turn that receipt into what lawyers call a legally robust informed refusal.
We need to understand the standard for 2026. Okay, so let's unpack this. Let's start with where the protection does work. When an AMA discharge is done correctly, what are the primary legal pillars a defense team relies on?
So when the documentation is handled correctly, it establishes three really powerful defenses. The first one is the termination of duty.
Okay, what does that mean in practice?
It means that if a competent patient refuses care, the law generally accepts that this action terminates the provider-patient relationship for that specific episode.
So your duty to physically treat them ends.
It ends. You can't be sued for malpractice for a treatment you couldn't give because the patient, literally walked out the door.
I can see how that's crucial, but doesn't that feel like a massive ethical escape hatch? Does the duty really just end?
Well, that's the nuance.
Right.
The duty to treat terminates, but the duty to warn and to support, that always remains.
I see.
And that leads right into the second defense, assumption of risk. This is the core argument that the patient voluntarily and knowingly chose to accept the specific warned risks.
Including things like severe harm or even death.
Yes. By refusing the recommended care, they are assuming that risk.
So the legal argument is, we warned you X, Y, and Z could happen, and you accepted that. You can't now sue us because X happened.
That's it, exactly. And the third pillar, which supports the other two, is evidence of refusal.
The form itself.
The form, but more importantly, the note. The detailed documentation serves as irrefutable proof that the patient was informed and still refused. It helps refute any later claim that the discharge itself was negligent. The whole structure really hinges on the quality of that evidence.
The quality of the evidence, that feels like the million-dollar phrase here. Because that shield only holds up if all the prerequisites are met.
Right.
So let's pivot. Let's talk about where the system completely breaks down. What are the critical failure points that turn that signature from a shield into a huge legal liability?
The sources outline three major vulnerability zones. And the first one, maybe the most absolute failure, is lack of capacity.
Okay.
The shield just vanishes if the patient is unable to make a rational, informed decision.
Can you give us a concrete example, something you'd see in a busy ER?
Sure. Think about a patient brought in after a trauma. Maybe they have a closed head injury and they're confused.
Or they're intoxicated.
Exactly. Or have a dangerously high blood alcohol level, or they're septic and delirious. If a patient isn't clinically sober, or if their cognitive impairment prevents them from, understanding the consequences of leaving,
Then their signature is legally meaningless.
it's worthless. Allowing them to leave AMA in that state could be negligence in itself because they lack the capacity to consent to the risk.
It's like signing a legal document while you're asleep. If you can't comprehend the risks, you can't legally assume them.
Precisely. And the second major failure point is inadequate disclosure. This is the huge difference between a generic AMA and a true informed refusal.
So this is about the quality of the warning.
It's everything. If a provider's warning is too vague, if the note just says, patient warned of risk and advised to stay, that fails. Legally, the disclosure has to be clear, specific, and it has to match the potential harm.
So if I'm the defense lawyer looking at that note, I can't just see risks of further illness if the patient had, say, clear signs of an impending heart attack.
It absolutely cannot. The note has to explicitly state, warned patient that leaving could result in myocardial infarction, severe organ damage, loss of function, or immediate death.
Wow.
If those specific high-stakes consequences aren't detailed, the patient's refusal is considered uninformed. And in court, that means it's invalid.
It sounds like the legal system is demanding a very specific, almost ritualistic communication of danger.
It is, Because the moment you move from generic risk to death, loss of limb, permanent disability, you establish legal proof that the patient had the information they needed to make a truly competent choice.
And the third failure point.
Poor documentation. Even if you had the perfect conversation, if the detailed summary of that conversation doesn't make it into the record, the defense is incredibly weak.
So that quick signature on the form is useless.
Useless. The power is in the narrative note that outlines the capacity evaluation, the specific risks you discussed, and the patient's actual response.
Okay, so if the note is the real defense, let's talk about building an unshakable one. This brings us to the new standard for 2026. What are the essential things a provider must capture to prove informed refusal?
Well, we've identified about 8 essential components legal experts require. But let's focus on the few that really make or break the case.
The cornerstones.
The absolute cornerstone is proving decision-making capacity. You have to document your formal evaluation. That means noting in the chart, patient is alert, oriented, clinically sober, and able to state their reasons for refusal and understand the consequence of a fatal outcome.
That is a huge step beyond just checking a box. You're actually documenting the thought process that confirms their autonomy.
Exactly. The other crucial element, tied back to disclosure, is detailing the specific risks of leaving and, this is just as important, the potential benefits of remaining.
So you can't just scare them.
No, you have to present the balanced argument. For example, patient refused admission, but acknowledged that remaining would allow us to perform the necessary angiography, which has an 85% success rate, you see.
You're making the cost-benefit analysis explicitly visible in the medical record. What about the patient's side of the conversation? What do you need to document there?
You need to document the patient's own reasons for leaving. Why are they refusing this life-saving care? If they say, I have to get home to feed my dog, you document that.
Why is that so important?
Because it demonstrates that they weighed a specific personal priority against the medical advice, which proves the refusal was a conscious, rational, even if it's medically ill-advised choice. And you also have to record their acknowledged understanding of the risks.
So you literally write down.
You literally document. Patient stated, yes, I understand that if I leave now, I could die on the drive home.
That level of detail transforms the document from just a warning into a transcript of the informed consent conversation.
That's a perfect way to put it. And we can't forget detailing the follow-up instructions. Even if they refuse treatment, you must provide clear instructions on when to return, what to watch for, and prescriptions for harm reduction if you can.
That confirms the provider still maintain their supportive duty.
It does.
Speaking of harm reduction, if the patient is refusing the ideal treatment, are you still expected to offer alternatives?
Absolutely. The duty shifts to offering the best possible harm reduction options. If a patient with a serious infection refuses AV antibiotics, you provide oral antibiotics and make sure they have a follow-up appointment scheduled for the next morning.
That shows the provider acted prudently to minimize risk, even in the face of refusal.
Exactly.
And our sources have a specific warning about avoiding coercion here. What's the danger of trying to pressure a patient into staying?
This is critical. Providers, in their eagerness to protect the patient, might be tempted to use false claims.
Like what?
Like telling the patient, your insurance company won't pay for anything if you leave AMA. That is largely a myth. And using a statement like that can backfire dramatically in court.
How so?
It can be interpreted as coercion or misrepresentation, which actually increases your liability. The approach has to be encouraging and factual, not threatening. You must explicitly encourage their immediate return if things get worse, and document that encouragement.
So the message is always, we disagree with your choice, we've told you the consequences, but we are still here for you if you change your mind.
That documentation of continued support maintains the high ground, both legally and ethically.
Let's transition now to the highest stakes scenario. What happens when not only is the AMA documentation missing, but the standard of care was already deficient? We're looking at a huge liability case, Cleveland v. Perry, which shows what happens when that defense is completely absent.
This case is a sobering look at how catastrophic a misdiagnosis can be when there's no AMA defense to fall back on. The facts start simply enough. The patient, Michael Cleveland, came to the ER with severe chest pain after shoveling snow.
A classic high-risk presentation for a cardiac event. The alarm bells should have been ringing immediately.
They should have. But the defense alleged that the physician, Dr. Perry, failed to adhere to the basic standard of care. This meant neglecting fundamental diagnostic steps.
Like an EKG.
like a timely EKG, serial vital checks, troponin labs, all the things you need to do to quickly rule out a heart attack.
Hmm.
The condition was allegedly misdiagnosed, and the patient was discharged.
Okay, so the negligence was in the failure to diagnose and treat a known life-threatening risk. But how did the lack of an AMA form factor into the legal proceedings?
Is the defining factor. The patient was discharged without signing an AMA. This just completely removed the defense's ability to argue that the patient had assumed any risk.
Because he wasn't advised against leaving, he was told he was fine.
Exactly, he was just released.
That shifts the legal focus entirely. If he'd signed a proper and firm refusal, the defense could argue he knew the risk and left anyway. Without it, the only argument is the diagnosis was correct, which it wasn't.
Precisely. And since the patient died shortly after arriving home, the case became a very clean analysis of proximate causation.
The legal question was simple.
Did the physician's failure to do those basic tests and correctly diagnose the cardiac event directly result in the patient's death?
And with no documentation to prove the patient was warned or consented to any risk, there were no mitigating factors.
None whatsoever. The court found that the doctor's failure to stabilize the patient was the direct cause of death, and the financial consequences, they were enormous.
What are we talking about?
Settlements in that region for similar failure to diagnose chest pain cases typically range from about $835,000 to well over $1.15 million.
$1 million plus. Simply because the fundamental standard of care was missed. And the critical step of either stabilizing the patient or getting a detailed, legally robust, informed refusal was bypassed. That just underscores the true stakes here.
It's the ultimate combination of vulnerabilities, a failure of the clinical standard, coupled with a total absence of a legal defense mechanism.
So, what does this all mean for you, the listener? We started by questioning the power of that simple AMA form, and I think the core takeaway is that the form is just the trigger.
Right, it's the receipt.
The legal protection is entirely wrapped up in the detailed, specific documentation, that narrative note, that proves a competent patient understood the severe, individualized consequences of their choice.
And that documentation proves the provider fulfilled their continuous professional duty. They terminated the duty to treat, sure, but they upheld the duty to warn, to support, and to facilitate the patient's safe return.
Which brings us to our final thought for you to explore. If a provider is required to continue offering alternatives, give detailed follow-up instructions, and explicitly encourage the patient to return, even after an AMA refusal is signed, does the professional duty ever truly cease? Or does the signature merely shift the focus of that obligation from active treatment to mitigating harm and maintaining communication? It suggests a continuous obligation, regardless of what the paper says.